I'm Carsten Utoft-Niemann. I'm a physician, a hematologist, and clinical researcher at Rigshospitalet in Copenhagen. I would like to give you a brief overview of how we are going to personalize treatment for CLL and how we are going to use data through the Persimmune data warehouse for this purpose. CLL, chronic lymphocytic leukemia, is the most common leukemia in the Western Hemisphere, and patients with CLL have a very heterogeneous disease course. Some of them will never need treatment, some patients will need treatment early on, and some patients have significant problems with serious infections. Actually, serious infections is a major cause of death in CLL. Realizing this, we aimed to personalize treatment for patients with CLL and using the data available, routine data from medical records to do that. The Persimmune collaboration and the Persimmune data warehouse offers way to standardize collection of data and to make these data available for treatment and for research. We use this platform to collect and assemble and clean, together with the Persimmune colleagues, data from more than 4,500 patients with CLL, and based on these data, more than 1,800 variables for each patient, we developed and trained machine learning algorithms to identify patients with high risk of serious infections and high risk of needing CLL treatment within the first 2 years from diagnosis of CLL. Most of these patients would not need immediate treatment according to current guidelines, but we know that they have a high risk actually of dying from serious infections before meeting the need for treatment. Thus, we wanted to identify these patients to see if we could actually improve management for those patients. Based on the data collected within the Persimmune data warehouse, we developed the CLL-TIM, the CLL treatment infection model, an ensemble algorithm. An ensemble algorithm, that's a machine learning algorithm compiled of a number of different algorithms to make it more robust. Robustness, in terms of clinical robustness, means that the algorithm can manage missing data. Thus, we can apply it across different cohorts of patients, different electronic health record systems, but still have a robust prediction. That's important when we not only aiming for publishing on algorithms in CLL and medicine, but aiming and actually implementing those across different health systems. Based on the CLL-TIM algorithm, which contains actually 28 different machine learning algorithms and has been approved in Denmark and validated in Denmark based on our cohort, but also on a German cohort, we have designed a clinical trial, the PREVENT-ACALL trial, to randomize patients with high risk of serious infections or early need for treatment for CLL, randomizing them between standard of care, which is observation, or a brief treatment with 2 targeted agents, venetoclax and acalabrutinib, to see if we can actually improve the infection-free, treatment-free survival for these patients. This trial is ongoing. But it's not enough to test new algorithms in clinical trial and use them for selection of patients. We also want to make these algorithms available for physicians treating patients in real life. The CLL-TIM algorithm actually uses more than 70 different variables, and a number of those variables being results of routine laboratory tests over 7 years prior to diagnosis. Thus, it's an enormous work for a treating physician or data manager or nurse to enter all these data into a web-based algorithm. Thus, we have also worked during the last 2 years to implement the CLL-TIM algorithm directly into the electronic health record system. And now we succeeded, based on an independent standalone Python platform, to design the CLL-TIM algorithm in a way where we can actually provide the results, the risk for individual patients, directly in the electronic health record system to the treating physician. This only has a 24-hour delay due to the way we have to manage the data to provide the prediction. Thus, we started out identifying a clinical problem for patients with CLL, that they have a high risk of serious infections prior to receiving any treatment. We used big data from routine electronic health records through the Persimmune platform to train a machine learning algorithm, the CLL-TIM. We designed a clinical trial, the Prevent-A-Call trial, currently ongoing to test whether we can improve the outcome for the high-risk patients, and we have implemented the CLL-TIM algorithm directly into the electronic health record system in a way where we keep track of exactly how we provide the prediction in the electronic health record system, and we are able to update this based on a standalone platform that feeds into the system. After having developed the CLL-TIM, CLL treatment infection model, we want to take this the next steps. To do that, we have increased the number of patients by continuing collecting data, and we have increased the disease areas from CLL to also including lymphoma and multiple myeloma, and we have increased the data sources by also including directly transferring data from Sundhedsplatformen, our electronic health record system, through CEK, the Center for Economics within the capital region. And by this we can combine even more data and develop improved models to provide decision support for treating physicians in real time. So that's what we aim for now in collaboration with a number of different data owners.